So I'm Matt. I'm one of the ECMO ICM consultants at the Glenfield. So this is a talk that I've done previously, and there'll be a second talk that follows on for it, not today, but another day, looking at strategies of management in hypoxemic respiratory failure. But I thought this would probably be quite a good place to start. So the objectives for this are really to have a look at classifying or the classification of hypoxia. Some genuinely useful equations, because I think we get taught lots of equations, particularly from an anaesthesia and intensive care point of view, most of which are completely pointless, but there are some that are genuinely more helpful. I have a little bit of a structure to think about, an approach to the hypoxic patient, and then a bit of pathophysiology on some interesting cases, which some people may have seen before. It's probably about half an hour. It shouldn't take too long. Okay, so classifying hypoxia. So I think the first thing to say is that hypoxia and hypoxemia are clearly different things, although they commonly are used interchangeably. But obviously, from the words themselves, they do mean something different. So hypoxemia is reduced partial pressure of oxygen in the blood, whereas hypoxia is low tissue oxygen levels. That may seem a bit semantic, but it is important because although they're commonly used interchangeably, they clearly mean different things, because you can be hypoxemic and not be hypoxic. So for those who have a microphone, can anyone think of when that might be the case? And Vaz isn't allowed to answer. Or type it. Okay, so if you think about it, if you think of climbers, if you think of someone at the top of Everest, they've probably got a very high hemoglobin level, and they can be hypoxemic, but because they're high hemoglobin, they don't have low tissue oxygen, so they're not hypoxic. And if you think of hypoxic, someone's hypoxic, but they're not hypoxemic, you think something like cardiogenic shock, where they've not got a problem with hemoglobin and oxygenation of blood per se, but they can't then get it to where it needs to be. So there is a reason that the two words are different. Okay, so as we've sort of already said, we can either have impaired oxygen delivery or impaired oxygen extraction. Okay. So the first equation that's worth thinking about is oxygen delivery. So if you've got delivery of oxygen, is going to be dependent on our cardiac output times by the oxygen content of blood. Okay, and the oxygen content of blood can be further broken down to that which is bound and that which is dissolved. And then you've got the two elements there for the bound part and the dissolved part. And bear with me because this will sort of make sense in a little bit. So the majority of oxygen in the blood is bound, so about 97%, with a small amount which is dissolved, as you can see from sort of the fudge factor there of 0.003. And normal oxygen delivery in health is about 1,000 mils per minute, and the utilization at rest is probably about 250 mils a minute. So we've got an oxygen utilization of about 25%. So clearly within that, there's a large scope for increasing the amount of oxygen that is utilized without any issue or without causing hypoxia. Slides are moving very well. Okay, but the problem with that is that in something like sepsis per se or other critical illness, the oxygen delivery and the oxygen utilization curves has shifted to the right. So essentially, you've got a hypermetabolic state where the baseline oxygen consumption is much higher, which brings the oxygen delivery up to the point of utilization. Okay, so there's very little wiggle room when you get to that point, and that's important. Okay, so if we think about the oxygen delivery equation, this can then be broken down to these key bits, which I've coloured in different colours, and that then gives us our different types of hypoxia. And this is the way that you can then think about using this equation to treat these certain elements. So if we think about the first part, we've got cardiac output. So therefore, that's going to be our circulatory form of hypoxia. We've then got hemoglobin, that's our anemic portion. We've got the blue part, so saturated hemoglobin, and the dissolved part, so that's hypoxic. And then we've got cytotoxic, which doesn't really fit into any of those categories, but it's worth thinking about. Okay, so we think first about hypoxic hypoxia, and we can think about these various different things. So I'd ask people to say something and come up with something, but I think people are going to be muted, so we'll just go through them. So we can have hypoxic gas mixtures, so low FiO2s, hyperventilation, diffusion limitation, shunt, ventilation, diffusion, inequality, and that's essentially ones that we can look at. So there's 5 different things there that we're going to just speak a little bit more in a little bit more detail. So the first thing is low FiO2. So this is sort of pretty self-explanatory, isn't it? So if you inhale hypoxic gas mixtures, then you will have hypoxemia and therefore hypoxia. Okay. And there's something called Dalton's Law, which people may be familiar with. Is anyone willing to pipe up? Dr. Whitman looks on the edge of a seat where it tells what Dalton's Law is.
Dalton's law of partial pressure, saying the pressure exerted by a gas is the sum of the partial pressures of the gases within that mixture.
Fantastic. Yeah. So what's the relevance of that then? Why is that important in this context?
So essentially, if you've got a low fraction of oxygen, that oxygen's going to have a lower partial pressure of that mixture, and therefore even if you're breathing at room atmosphere or 1 atmosphere, then the partial pressure of oxygen is going to be lower. Likewise, if you go to altitude, then the total pressure is reduced. And even if the fraction of oxygen is the same, the partial pressure of that oxygen is lower because of the lower pressure, and therefore you can get hypoxia.
Yeah, that's absolutely right. So the important thing, Dalton's law, essentially, as you quite rightly said, is the total pressure of a gas mixture is made up by its constituent parts. So if we think of the case of air, then the percentage of oxygen that's in air is about 21%, isn't it? And that's the same irrespective of the total partial pressure of that gas. So if you're up at altitude where the partial pressure is significantly lower, therefore, although oxygen still makes up 21% of that gas mixture, the absolute amount of oxygen in that mixture is significantly less, and hence you become hypoxic. That sort of makes sense. So it's sort of fairly self-explanatory, that one, but it's worth bearing in mind because obviously we do come across those situations and they're very, very, very easy to fix because you just give oxygen. Okay. So the second one is hyperventilation. Okay, so these are going to be, there's a myriad of causes of these, but these are all the things like drug-induced, neurological, metabolic alkalosis, lots of different things that can cause this. Okay, and you've got to bear in mind that the alveolar PO2 in blood is determined by the rate of its removal and the rate of replenishment by alveolar ventilation. So there's these 2 equations here. So you've got the alveolar gas equation, which I'm sure we're all fairly familiar with, and the alveolar ventilation equation. And as I'm sure you can gather from looking at this, from simple maths, if you half the minute volume, you'll double the amount of CO2. And then when you plug that into the alveolar gas equation, you can see that the higher the CO2, the lower the alveolar oxygen concentration, and therefore the lower amount of PaO2 when you get into the blood side of it. Okay, does that sort of make sense as well? Fairly straightforward. Obviously, these things as well, the respiratory quotient can be changed. And as we've already mentioned, the PiO2 is dependent on the partial pressure of oxygen in the gas that you're breathing. But those things, if you think about it from our point of view, at sea level are fairly fixed, and the respiratory quotient, although you can change it ever so slightly in clinical practice, it doesn't really make a huge difference. Okay, so key things with hypoxic hypoxia, which are due to hyperventilation, is that they'll always increase the PCO2, which makes sense. And it decreases the oxygen unless additional oxygen is supplemented. So that's where we can fall into a slight problem with things like conscious sedation or unconscious or deeply conscious or anesthesia without monitoring, whichever you want to call it. But essentially you can get to the point where, because we give supplemental oxygen, we don't recognize the fact that they're becoming increasingly hypercapnic, because all we're really looking at is an SpO2. But the key thing with hyperventilation as a cause of hypoxic hypoxia is it's very easy to fix. Okay, so diffusion limitation is the next bit, and as you can see, there's the oxygen cascade. So we've got all different bits that we can look at from this point of view. So coming from room air all the way down to the oxygen levels in the mitochondria, and there's different processes that we'll have learned along the way where you can calculate why the oxygen content drops across these different points. And this is where there's a lack of equilibration between alveolar oxygen and capillary oxygen. In the normal conditions, the PO2 difference between alveolar gas and alveolar capillary blood is immeasurably small. So it's normally very, very, very small and not significant. Conditions that cause diffusion limitation, anyone think of any? There's lots. If you name a respiratory condition, you're probably going to be right.
lung fibrosis.
Very good, Kaya. Are you hiding?
I'm in front of the computer, not hiding, just the camera is set up as it is set up.
Oh, there you are. Okay. Yeah, so you're right. So there's absolutely loads of them. So anything that causes an increase in diffusion distance, so asbestosis, organizing pneumonias, interstitial fibrosis, there's tons. Okay, vasculitis. However, there is always an element of VQ mismatch within these conditions as well, which isn't strictly diffusion limitation. Okay, you can also get diffusion limitation at extremes of exercise, where the red cell's got a very, very short time in transit through as it moves through the alveolus, or adjacent to the alveolus. So that can also be an exercise-induced diffusion limitation. Key facts about that one. So occurs in conditions increasing diffusion distance or decreased diffusion area. Again, that's fairly self-explanatory. We spoke about the exercise-induced version. But it's very difficult to measure precisely in clinical practice. So we can use things like transfer factor when we do our pulmonary function tests to get a measure of it. Okay, next one would be shunt. So this is the shunt equation, which at some point probably one or all of us have been asked to define it during an exam, which is deep joy. And this is essentially where blood moves from the right side of the circulation to the left without passing by ventilated lung units for whatever that reason may be. And you can calculate the amount of blood that is shunted via this equation. So just hence why they teach it, because it's of academic interest. Shunts can be either anatomical, so where there's a direct physical connection between two things, such as ones that are physiological, so intracardiac shunts, shunts within the respiratory system, but there's also pathological ones, things like AVMs or hepatopulmonary syndrome, etc., that are more anatomical type things. You can also have physiological shunts, so where you've got non-ventilated alveoli that are perfused, so where you've got atelectasis or disease of the alveolar filling, things like pneumonia or ARDS, they cause shunts that are physiological. And again, I said we can calculate the amount of shunted blood. Okay. Key things with shunts is that you can't abolish them by giving 100% oxygen, so that's important because that's a good way of trying to define them clinically. But that doesn't mean that the PaO2 won't rise if you give oxygen, because obviously there'll be bits of the lung that are ventilated which will be involved in gas exchange, and therefore the PaO2 will still go up to a certain extent, but it won't go up as much as you would expect it to. And the PTO2 will likely be normal or low normal, as opposed to things such as hypoventilation. Okay, that's to do with solubility of CO2 and ventilation, etc. Everyone still with me? Not too bad? Good. I can't hear you even if you are, so that's good. Okay. And then the final one for hypoxic hypoxia is ventilation perfusion inequality. So these are the West zones that I've described from a lung point of view. These are very uncommon. Sorry, these are common, obviously, because they happen all the time. And they're responsible for most, if not all, of the hypoxia we see in things like COPD and interstitial lung disease, vascular disorders, PEs, that kind of thing. And obviously in the upright lung, we have these zones, and it's physiologically normal to have ventilation perfusion inequalities because of the differences between where gas rises to and blood falls to, essentially. And that's what these West zones describe. And these are responsible for the normal physiological A gradient, which we'll talk about in a little bit more detail a little bit later. Okay, so those are the sort of hypoxic ones. We're not going to talk too much about the others, I don't think, from just looking through my slides, because these are the ones that are sort of most relevant to this talk. And the others, in terms of cardiac output, anemia, and the cytotoxic ones are probably more self-explanatory, really. Okay, so think about a case. So we've got a 49-year-old male. At the beginning of February, he has a right pneumonectomy and a pericardial patch and partial pleurectomy, which is all relatively uncommon, relatively uneventful, sorry. And he has a sort of normal post-operative course. And about a week later, goes home. So pretty much as you'd expect for anyone having a pneumonectomy. He then represents at the beginning of March with a week-long history of increasing shortness of breath. He's cardiovascularly stable, his temperature's normal, and his respiratory rate is 30, so he's a bit tachypneic. Okay, so we do what we always do, and we do a gas, and this is what it looks like. So on 8% oxygen, he's a bit alkalotic, he's hypocapnic, he's got PO2 7.1, so it's very low in the context of that amount of inspired oxygen. His bicarbonate is normal, his base excess is normalish, his lactate's normalish, so nothing too remarkable there. Okay, so if we think about our causes of hypoxic hypoxia, which ones can we get rid of pretty quickly from the information that we've already had?
He's not got a low FiO2.
Yep. Any others?
Hyperventilation.
Yeah, exactly. Absolutely right. So we've not got low FiO2 because we're giving a high inspired fraction of oxygen, and we've not got hypoventilation because he's not hypoventilating. He's got respiratory at 30, and he's hypocapnic. Okay. So, as I said, we'll talk a bit about the AA gradient, and this can be useful to rule out certain things or rule in others. So, Kaya, what's the AA gradient? The answer's on the screen.
So it's a difference between the alveolar concentration of the oxygen and the one in arterial, the partial oxygen concentration in the artery.
Mm-hmm. Yeah, that's absolutely it. So you can use this sort of equation at the bottom as a conservative estimate of what you might expect it to be, but it's normally in an adult, not an elderly adult, but in a sort of normal, that's the wrong word, but a youngish adult breathing room air, it's normally about 5 to 10 millimeters of mercury. But with increasing age and increasing fractions of inspired oxygen, the air gradient does change, and that's physiological. So is it useful? What do people think? What's the point in measuring it?
So it is useful, but because it gives you the idea how thick is the membrane, how much the oxygen cannot pass through to reach the bloodstream, so subsequently oxygenate the tissue.
Okay. So yeah, I mean, you either end up with a number that is a normal air gradient for the amount of oxygen they're breathing, or it's high. And that means realistically it allows you to split the causes of hypoxic hypoxia into ones that are low fractions of inspired oxygen or hyperventilation has a normal air gradient, or all the others. So it sort of helps, but not hugely, because as we've already sort of said, you can rule out the first two by just looking at the history, looking at the gas. But nevertheless, it's something that we still do. Okay, so this guy's air gradient was 64, so it's very, very high. Okay, so it comes into that second category of the others. Okay, but we knew that anyway. And this was the chap's chest X-ray. So anyone who's not Kaya, want to comment on that? Like one of the F1s that's in the background of your room there, Kaya, they'd be perfect for it.
The answer is that it's not good.
Not good. Okay, the actual answer is it's probably pretty normal for someone who's had a pneumonectomy. So although it looks dramatic, he's had a right total pneumonectomy. So he's got an air fluid filled space, which is mainly fluid with some air at the top. Obviously it is extra pleural, but that's because there isn't any lung there. And there's obviously a meniscus there. That's actually pretty normal for a post-pneumonectomy X-ray. What's probably more important is to comment on the other side. So if we look at the other side of the remaining lung, it looks pretty pristine, doesn't it? So you can see all the way down at this costophrenic angle. The lung field itself looks remarkably clear, so it doesn't look like there's any signs of pneumonia there. Okay, and that's quite important. So when I saw this guy on the ward, he was being treated for pneumonia, but I couldn't quite work it out because it didn't make a lot of sense because his chest X-ray was totally clear. He wasn't pyrexial. His inflammatory marks were normal, but he was quite hypoxic, obviously on quite a lot of oxygen. So we've ruled out a couple of things. Is there any others we can rule out now, given the history and what we've seen so far?
Diffusion limitations?
Yep. Why is that?
Well, the remain lung looks pristine. I didn't catch up why he had a pneumonectomy, but I suspect it could be for a cancer. So the remaining lung is okay. That means that the barrier should be fine. If we had consolidation, then we could think about the difficulty with the transfer of the oxygen. So despite the exclusion, I might be wrong though.
No, you're absolutely right. So diffusion limitation essentially is ruled out because the remaining lung is normal. And as we mentioned, there's none of the other causes that we've seen for diffusion limitation. And likewise, ventilation, perfusion inequality, if we said he's had sort of a CT scan that looks normal from that lungs point of view in terms of there's no PE to see, there's obviously nothing on the chest x-ray to report, there's no evidence of ARDS from what you can see on there. So essentially, we're pretty happy it's not going to be diffusion limitation or ventilation perfusion inequality. So that leaves us with shunt. Okay, so why has this guy got a huge shunt that he didn't have when he left 3 weeks ago? Vaz can answer this one if you want.
P.
No.
Did he have cardiac disease?
Okay, so this is something that sounds very, very interesting, but as usual, it's just sticking some Latin words together. So platysmia orthodeoxia syndrome. So it's something that's probably underdiagnosed in patients who've had pneumonectomies or other reasons why they might have raised pulmonary pressures. And what essentially it's describing is someone who has positional dyspnea and hypoxemia. Now, don't worry too much about this condition. The main point is that from using what information we've had previously, we've managed to get it down to what it can be, which is it can only be shunt. Okay, so it can't be any of the other things. And that means we can use that in terms of our treatment or things that we might want to do moving forward in further investigations. Okay. And the interesting thing about this condition is it's dyspnea and hypoxemia, which gets worse when you sit upright. Okay, so all the things we normally do in patients who are hypoxic is sit them upright, give them oxygen, etc. None of those things would work. In fact, they'd actually make the situation worse. And in this guy, by laying him flat, his hypoxia got better. Okay, and the reason that happens in this condition is that you get a change in pressure between the right and the left atrium on change in position. So as you sit upright, the pressure in your right atrium goes up. Okay, which means that you end up with a shunt. Now, in this case, this chap had an absolutely normal echo before his operation because that's part of their workup. But what happened is over the course of time, as this vasculature remodeled in the other lung, he ended up with raised pulmonary pressures after having his pneumonectomy, which meant that over time he ended up with an element of pulmonary hypertension, and that caused a PFO to open across that wasn't there preoperatively, or it was shut and then reopened. So this is a bubble study. I think this is his, but I can't quite remember. So essentially, you're injecting agitated saline into the venous system and then looking to see how many bubbles get across into the left side. And you're looking for a certain number of bubbles within a certain number of cardiac cycles. I think it's about 3. So this would give you some echo evidence that he's essentially got a PFO that wasn't there beforehand. Okay. And as we said, the reason is that because he's had an increase in pulmonary vascular resistance, which has led to an opening of a PFO, which means that he then has blood that can get shunted across from the right to the left without completely bypassing the lungs. I should probably change. We need to probably get rid of Donald Trump off here and put someone else on it. We've got plenty of our own prime ministers we can probably put in his place now, to be honest with you. So don't worry too much about the condition itself. It's more to just emphasize the point that by using a systematic approach to a hypoxic patient, we can rule out certain things, and don't just get stuck on the fact that because someone's got a low oxygen and they've had an operation recently that it has to be pneumonia, because that isn't always the case. And from looking at the evidence that we have there, that clearly wasn't the case because the lung that was left was completely normal. Okay, everyone reasonably happy with that? Okay, so just thinking sort of slightly off track a little bit, what do people think about these gases? So these are some gases that I saw not too recently, but in the recent past for a patient. Apart from the fact that
that's quite bad.
Apart from the fact that they're bad, yeah.
I mean, I'm sorry, I think we cannot distinguish in terms of the arrows, are they going high up or high down, but equally, I think it's the bad situation for the patients to be, because the pH is or very, very high or very, very low. Yeah. It's just, I cannot see, I think we cannot just establish what's occurring, but it's bad.
So I suppose the reason for showing this is that these are not gases that you will ever really likely see in someone who's alive most of the time. And this guy wasn't alive for a huge amount longer after we'd taken This chap had a massive PE on the ward, and he actually made it up to ITU, but not for very long. But this is an interesting point just to think about. If you look at the PO2 on this one, it's 8.5, but the saturated hemoglobin of the SATs at 54%. Now, if you think about it, from when we learned to draw the oxyhemoglobin association curve, SATs at 50% is normally PO2s of 3.5, and we've frequently got patients who've got PO2s of 8.5 with SATs in the 90s or high 80s at the very least. So why is that the case then? What's the reason?
Is it because of acidosis, and I mean at the tissue level, and the lack of dissociation of the oxygen at the tissue level, so it cannot penetrate through the skin? And I mean the red cells, when they are going through the fingers, when they pick it up on the saturation, and it's in the gas. So yeah, it's due to acidosis and difficulty of the dissociation of the, actually giving away oxygen faster than we're supposed to do.
Yeah, so this just emphasizes why I mentioned at the beginning that some things we learn aren't helpful at all, and others that you don't think are useful at the time actually probably are. So this just emphasizes the oxyhemoglobin association curve, doesn't it? So this has got a massive right shift because the patient's so acidotic, and they're so hypercapnic, etc., that you've basically got a huge right shift. So for a higher partial pressure of oxygen, you've got a significantly lower saturated oxygen, O2 level. So it's really just to look at that. But the other reason is I've never really seen gases like this before, and I like to share them because it's quite unusual to see this in someone who's alive, really. Anyway, okay, so my approach to the management of a hypoxic patient, essentially, initially, and obviously I've said we'll think about more advanced things the next time we have a chat. The first thing is to ignore COPD. So the teaching about patients having a hypoxic drive is nonsense, really. It's got such a small impact. The main reasons why COPD patients are sensitive to oxygen is that they've got a loss of hypoxic pulmonary vasoconstriction, which means they end up with a huge increase in dead space ventilation if you give oxygen, and the Haldane effect, so that red cells that are in a hypoxemic environment more readily bind and give up CO2. So those are the two main reasons why we have to worry about oxygen in patients with COPD. But the key thing, as always, is give oxygen. If we think about the other bits, so cardiac output, aim for a normal cardiac output, so an index of like more than 2.2 or 2 litres, aim for a HB of greater than 7. Try and aim for SATs of 88 to 92. I'm not really bothered about PO2 that much, because the reason is obvious, because it makes up such a small portion of the amount of oxygen, and then therefore its impact in terms of hypoxia and hypoxemia is low. So the SPO2 is more relevant, which is why we just basically ignored this with COVID, because one, it was a pain, and two, it doesn't really matter. Try and aim for a PO2 greater than 7.5. That's what we tend to advise. And if they've got no evidence of right ventricular issues, then aim for a PaCO2 that's associated with a pH of greater than 7.2. And that would be sort of my basic things for managing hypoxia initially, and then think about the other stuff and working through sort of different causes of hypoxia after that. But by giving hemoglobin, by treating the cardiac index, etc., then you've already treated these two. The other one that obviously isn't mentioned is the cytotoxic things, but they're sort of a bit more weird and wonderful, and normally there's some kind of clue in the history as to what that might be. And that's pretty much it. I don't know if anyone's got any questions on that. It's just sort of a whistle-stop tour through hypoxic hypoxia, really, and we'll have a chat about more managements of refractory hypoxia next time. I think Kaz is going to talk about RDS next time as well.
Hi everyone, my name is Kaz. I'm one of the clinical fellows working in intensive care in Leicester Infirmary, and I'm going to present a study which is association between timing of intubation and clinical outcomes of critically ill patients, and is a meta-analysis. This is the study which is combination between the Greek hospital in Athens and a center in New York. So while the authors, I think we can all agree with this in terms of the backgrounds, that determining of the optimal timing of the intubation, a critically unwell patient is a bit of unknown. Early intubation carries risks of ventilatory-acquired pneumonia, airway injury, need for sedation, and cardiac arrest. So what the authors decided to do is conduct a meta-analysis to investigate the association between the timing of the intubation and the clinical outcomes for the critically unwell patients. So I'm going to talk a bit about the methods. So they used Prisma, they registered the protocol with Prospero, and they looked at the papers which were published up to November last year, and later on they changed to the 20th of November last year.
Oh.
So that was the background, methods, and strategy. So what they've done is they use a PubMed database. They decided to research words such as intubation, timing, early and late, critical and unwell, but they excluded everything that is related with the COVID-19 patients. They didn't use the language restriction. As I mentioned, it was up to November last year, and they involved the observational studies and RTCs. The exclusion criteria included patients below age of 18, any observational studies with the less than 5 patients, and COVID pneumonitis, any studies related to COVID pneumonitis. So then they decided to extract lots of data, and they divided it between the country of origin, definition of early intubation, numbers of intubated patients, and some clinical characteristics as well as outcomes. When they didn't find the data, they decided to contact the author of the study and get them directly from the person who published. It's worth also mentioning that there were 2 people separately working on the data collection. So they assessed the risk of bias for the randomized control studies and for the observational groups, as they were included in this meta-analysis. And then they came to the definitions itself. So they decided to go with early and late intubation according to the authors of the paper. But if it was not provided, they decided that the definition of early intubation will be within 24 hours of admission to intensive care, and late intubation will be more than 24 hours. They do that quite, so they decided to create a couple of subgroups in terms of the analysis of the data they collected. So they specifically designed one subgroup into early and late intubation. They, as per definition, using 24 hours cutoff. They also created the subgroup with the studies with the low risk of bias. And they also divided the meta-analysis for the design group, and there was a specific design group for the patients with patients who are immunocompromised, and it makes more sense when we are going through the data itself. Then a busy slide that they used the review RevMen to conduct a statistical analysis, and then about the outcomes itself. So what they were looking, the primary outcome of the meta-analysis was the all-cause mortality, and the secondary was the length of stay, duration of mechanical ventilation, need for vasopressors, and renal replacement therapy. So let's look at the results and the numbers. So initially, they found 320 records in the PubMed. Straight away, there were 117 titles which were excluded from the study, and as for the reasons as listed. Subsequently, 181 were excluded as there was no data on the intubation. So they left with 4 studies, and then they had the 23 studies which were retrieved from the references for the original article. So altogether, they had 27 studies, a population of more than 15,000 patients, and then studies originated, it was worldwide. Most of those studies were observational. In terms of the outcome, so this is a busy slide. This is a nice forest plot in terms of the outcomes of the studies. So what they conducted is in all-cause mortality was lower in the patient undergoing early intubation on the intensive care, and that was statistically significant. In terms of the other subgroup in their analysis, this outcome was repeated. So we are talking about the definition of the early intubation less than more 24 hours in a group with the low risk bias in the observational studies as well as immunocompromised patients. In terms of this secondary outcomes, there were only 5 studies that commented on that. And there were 3 studies that commented on the stay on intensive care, but that was not, it was shorter, but it wasn't significant, statistically significant. There was only 1 study which suggested for the need for the vasopressor, and 1 study for the renal replacement therapy. In terms of the discussion, so the conclusion of the authors of the study that this meta-analysis that demonstrated that the all-cause of mortality was lowered in the patients which were undergoing early intubation versus late intubation in the patient with respiratory failure, based on 15,000 patients, 27 studies. Of course, it's mentioned without patients without COVID-19 and in all subcategories. 11,000 of those patients, what is worth mentioning, were immunocompromised. And the authors mentioned that actually each day the patients remained not intubated. In terms of day from admission, the mortality is higher. They also mentioned in the discussion that the decision to intubate was multifactorial, and they talk about the clinical assessment all the way through the staffing on the unit and the experience of the patient, of the doctors who are working on the intensive care. They do acknowledge the limitation, and they mentioned that the most was the early intubation of the clinicians, the fact that the it was mostly observational studies. They do acknowledge that we very common using non-invasive ventilation such as Optiflow or CPAP for the patients. And that can give us skewed results. And also they said that they use only PubMed database. So I thought about, raising this question in discussion because I quite struggled with the studies, especially looking at the some of the interesting tables that were attached. So looking at the table, which I've got it in the end of the slides, I'm happy to demonstrate that actually only 4 studies were, and they mark it in the table, had actually the definition of the early intubation, and it varied between 12 hours to 48 hours from admission. There was lots of other data collections such as sex and the severity score, and there was no mention of this correlation in the meta-analysis. The other thing is that most of the studies, and it's also showed on the busy table, were immunocompromised and the cancer patients, and most of those cancer patients were patients with the lung cancers. There's also 1 study included that is trauma patients. So the variety of studies is quite interesting. Lastly, looking at the paper, there's loads of statistical analysis. I mean, this is meta-analysis patient, lots of tables. But overall, I think that we attempt to do a really good assessment of the literature in terms of the trying to optimize the timing of the intubation. I just don't know. I think that in terms of clinical practice, what do you think about the studies? I don't know if anyone had a chance to browse through it. Thank you. And that's my dog Nala.
Cheers, Kai. What do you think, Kaya?
I think that about the study, about a practical approach to that, to the intubation of the patient.
Probably both. What about the study? What do you think? What are you going to take from it?
So I think I just showed this table. So this is the table that is displayed in the study. They collect loads of data that they don't collect. So definitely, I mean, I struggle with the study because there's so much statistic involved, and they've done so much recalculation that I cannot really understand that. Okay, and I'll be honest about it.
Mm.
I've noticed that there's lots of data collection, as I mentioned, in terms of the age, immunocompromised patient. I mean, that wasn't in the primary thesis. I marked some stuff because there's so many things here. So the red one is actually, you can clearly see that there's a definition when they mention that they're supposed to exclude those studies. And in the blue and in the yellow, yellow is the cancer patient and blue are immunocompromised patients. I mean, so the take from that is it's about, I think, I don't know, is it a good, it's a good attempt of reviewing reviewing the, you know, papers and meta-analysis, but I don't know if the data speaks for itself. But in terms of clinical practice, I think it's variable. I think it's very worth acknowledging that we are using CPAP and, you know, and OptiFlow. So I think it's very much clinical decision in terms of timing of intubation. But yeah, I don't know. What do you think about it?
Yeah.
I might be completely wrong.
No, I think it's interesting because we know from other published stuff that essentially patients who are immunocompromised, for whatever the reason may be, have normally got a poorer outcome when you look at early versus later intubation, because normally intubation is a prognostically poor sign in those patients, particularly those with things like hematological malignancies and stuff along those lines. Although the thought regarding cancers probably isn't quite as straightforward as that. So there's actually reasonable evidence that cancer patients, even those with metastatic cancer, actually can have quite good outcomes on ITU, even with full organ support. So it's a bit difficult, isn't it? I suppose one thing that I think is interesting with a lot of these papers now is that because the only thing that we've really looked after from a respiratory point of view has been COVID for the last few years, and that the teaching on that is really to delay intubation if at all possible, because the outcomes seem to be better using non-invasive ventilatory techniques. I wonder how that practice of how people have managed COVID will have an impact on how they manage other things, such as other respiratory viruses or pneumonia for whatever reason, because obviously the teaching from that point of view is that if you avoid intubation, you actually worsen their prognosis, which is what that paper would suggest as well. And I think there's probably going to be a few things that get published like that in terms of reinforcing the fact that actually late intubation in pathologies that aren't COVID is probably not good for you, particularly if they're being managed outside of the intensive care environment where you can't immediately intubate them. So I don't know. I'm not sure really. It's interesting. I think they've tried to look at the available stuff that's there, but it's just interesting that so many of them are immunocompromised, and how you can therefore expand that out to other patient groups. I'm not entirely certain, but two-thirds, wasn't it?
Yeah, I mean, what's interesting is how did they manage to actually gather so many papers on actually immunocompromised and cancer patients, because I'm pretty sure there's loads of, I think there's from that spread, because I tried to look at the list and the title of the studies that they incorporated in the meta-analysis. So so there's really like one or two maybe on sepsis and pneumonia, one on trauma, and it's really, 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 I don't know how do they manage to just, is it PubMed just full of the immunocompromised and, you know, cancer patients studies? Is it because, you know, it's again, I think the issue is European, most of them, they're European studies, and, you know, they don't have maybe limitations of care, you know, and everyone is deemed for intensive care and resuscitation. But yeah.
It could well be. I think obviously that timing of intubation in patients with immunodeficiency, for whatever the reason may be, is an interesting area, which means there's probably more publications on it looking at that specific group, as opposed to some of the other pathologies where we know that delaying intubation has a poorer outcome. So that's probably why they've picked up more of those studies. I think the big question, as with anything that you read, is what is it? So what does it mean to you? How is it going to change your practice, if at all? I suppose the answer is they probably won't.
Yeah.
So Eamon's just put, or someone from the LGH, sorry, is just put in there, I think they should have concentrated on one pathology or clinical cause for intubation for the study to have any benefit. I think that's right to a certain extent. You need to sort of keep your question very focused to try and therefore work out how much of that is applicable to the patients that we're looking after, rather than having all comers. So that's a very good point.